Good afternoon. Thank you very much for joining us today for our Healthy at Work webinar series. This one is titled Equity, Diversity, Inclusion, Anti-Racism, and Indigeneity at Work. We are delighted to have Sarah Mushtaq, Director for Equity, Inclusion, Diversity, and Anti-Racism at Windsor Regional Hospital, presenting for us today. My name is John Beveridge. For those of you who don't know me, I am the coordinator for Occupational Health and Safety at Windsor Regional Hospital and chair of this committee, the Working Towards Wellness Committee. Jeff McEwen, Manager of Recreation Services at St. Clair College, waving, will be moderating the webinar today. Okay, he'll be keep an eye on the chat box and if there's questions and things of that nature. Before we begin, with respect to audio, just make sure your speakers are on, volumes turned to the appropriate levels. You should be able to hear and see us. If you have any questions, we encourage you to post them in the chat box. We'll try to move through the presentation and do our best to answer, any questions that at the end of the presentation. Okay. After the webinar, as we have been doing, we are recording, so we will be making the recording available. We'll send a link out and we'll be posting it to our website as well. Okay. Okay. At this point, I'm going to call upon Sarah to read for us the land acknowledgement.
Thank you. Hi, everyone. Happy to be here and happy to chat with everyone today. Hopefully we'll have a great conversation together. So just starting by, honoring the land that we are on. I think most of people, despite being virtual, we are in Windsor-Essex or in the surrounding areas here. And this is the traditional, ancestral, and contemporary lands of the Three Fires Confederacy, which is made up of the Ojibwe, Odawa, and Potawatomi peoples. So just wanting to make sure that we acknowledge that and honor, the original inhabitants of this land for their work in protecting its land. I also try to always reflect on my personal journey. I'm the daughter of South Asian immigrants who settled on this land, and so much of the opportunity we've had and that I personally have had wouldn't have been possible without the opportunities we got from this land and from, the benefits from the original inhabitants of this land. So I hope that everyone also takes some time to kind of reflect on their personal journeys with the land here in Turtle Island, but also with the original inhabitants of this land as well. So I will get started here. Talking about, as John mentioned, what EDI work looks like in a day-to-day kind of capacity, as well as some of the definitions. I know some of this might be information that you guys are all aware of, but just kind of going over it quickly and then looking at real-life impacts from a healthcare perspective, which with the caveat that I know everyone on this webinar is not in the healthcare space, but there's a lot of parallels to other industries, such as automotive manufacturing, the education space, public health, whatever it might be. So just know that there are parallels there, and I will try to point them out as much as possible. So, like I said, this is me. I've been in this role since August of 2022. Which both feels like I've started this last week, but also a very long time ago. And, the healthcare space has been really interesting lately with the pandemic over the last 4 years, but as well as a cyber attack that we just went through. So it's been an interesting journey so far, to say the least. I just want to start with the OHR Ontario Health Framework on EDAR, or that is the short form for the long title of Equity, Inclusion, Diversity, and Anti-Racism. This is from Ontario Health. It's on the Ontario Health website. This is what the Health Ministry and OH is using to base a lot of the equity work on. A lot of also other, EDI or equity, diversity, inclusion leads in the healthcare space are also using this framework, and we're trying to, kind of build our work around this. And so there's a lot of pieces here about some of the things that I just want to kind of emphasize, which again, like I said, are applicable to other industries, is the importance of collecting equity-based data. One of my pet peeves sometimes I talk about is the difference between Canada and the US when it comes to this. The US does a really good job of collecting equity-based data, socio-demographic data. There's a lot of good data in the States on what their populations look like in the healthcare space and the education space, whatever else it might look like. And the importance of having that data is that you can make data informed decisions about those populations. And so, I think sometimes there is resistance in Canada on our end that we think that collecting this data can sometimes either reinforce racism or inequities. And there's, a conversation to be had there about the weaponization of data, making sure data is collected safely and well for everyone. But the benefits of collecting this data, I think, outweigh a lot of those risks. And as long as it's done safely and in conjunction with community, it really helps us to inform a lot of the decisions we make and make sure that we're not making these decisions, kind of in a vacuum without a bigger picture. The other thing I want to emphasize from here is the specific focus on anti-Indigenous and anti-Black racism. So, there's a lot of inequities in the world. There's, inequities against, women, sometimes even men in certain scenarios. There's inequities against racialized groups, inequities against folks from the LGBTQ community. But when you look at the history in Canada, the inequities against Indigenous and Black people have been above and beyond any other group. They're often systemic, they're often part of legal rulings, and that kind of trickles down into all different aspects of our world. And so having specific strategies to address those inequities is really important. It is Black History Month. We, I think a lot of us have been part of, teachings, learnings, groups, learning more about the history of Black people in our community and across the country. And then, the same goes with Indigenous folks. There's been a lot more education in the last little while of understanding the impacts of colonization on Indigenous folks, over the last few hundred years, and how that is still having real life impacts, in the healthcare space, but also in other sectors as well. So just wanted to emphasize that here as well. So speaking about my role, I'll spend a little bit of time on this, but, this was kind of the pitch initially for this role. So just sharing that if folks are interested in this and, looking to kind of do that in your specific area as well. Looking at in a hospital setting, what does this mean? What does it mean, for patients? What does it mean for staff who are working in our hospital setting? If people have a language barrier, do we have the resources and the tools for them to come in and access healthcare despite not being able to speak English or potentially having low fluency in English, right? What do we do when it comes to dress code policies? So for example, I'm wearing a hijab. I'm non-clinical though, but if there is someone who's a nurse or a physician or a respiratory therapist, what does it mean for them to wear a hijab in a clinical setting? And what does that look like? And so that applies to a lot of other industries, right? So if there is someone, for example, who wears a turban and is working, let's say in an auto manufacturing kind of setting, is there abilities for them to wear safety gear, hard hat, glasses, whatever else it might be, while still respecting the fact that they wear a turban and that it's an important, religious choice to them. So, there's a lot of parallels here. And everywhere. So, a lot of my work is looking at our policies and looking at our practices and seeing how we can improve that. And then also talking to, looking at our patient complaints and seeing what may have come up and where there may have been a gap. And then also looking at feedback from our staff as well to make sure that we have practices in place that allow staff to be, feel as included as possible. I also want to emphasize the importance of community connection. So, these are just lists of some community groups that exist in the community. Obviously, not all, but there's a lot of them. The point here is that there's the quote at the bottom of this slide is a quote from disability activists, and it says nothing about us without us. So I think a lot of this work sometimes can feel overwhelming. Sometimes people feel that they may say or do the wrong thing, so err on the side of caution of doing nothing at all. But I think doing work with communities and in conjunction with the people that we are trying to help helps alleviate a lot of that, right? So just talking to people, building relationships, being able to say, hey, like, we want to do better by, for example, we'll use someone using a wheelchair. What is their experience coming into the hospital? What does that look like? And how can we make that better? Especially in the context for us right now, was we're building a new hospital. We want to make sure that those sort of things are built in into our new build as well. And then making sure that we have, that sort of conversation. It's a two-way street, through advisory groups or tables if possible. A lot of times feedback from community groups is that it's like a top-down approach. And that sometimes can be incredibly frustrating, especially when community groups feel like they've told their story several times and then there's no change, right? So being able to say like, hey, we heard you, we are now implementing XYZ based on the conversations that we've had with you. And this is, we'd love to hear your feedback on, does this work? What's missing? And how can we move forward on this? I also wanted to share just as a resource, these are the Indigenous, my apologies. These are the EDI leads or the kind of folks in my sort of role across the hospitals in our region. And so we've been able to get together and kind of create a community practice, which is really helpful for us since we work closely together. All 5 hospitals in the region work together in Erie St. Clair. But also sometimes it's great to share, right? Someone may have started on something and then is able to share that with, others in the group and rather than recreating it from scratch. So this is who are in the roles currently in the Erie St. Clair region. So then just quickly, I want to go over the definitions. And like I said, I know a lot of folks have already gone over this, so I'm just here as a reminder, but nothing in too much detail here. But I do want to emphasize the difference between these terms. So I think this is a personal pet peeve of mine, but when folks say that, diversity is our strength or diversity is the end goal, I often want to remind folks that diversity is just a snapshot of our community or of the organization or of the group in question. So diversity to me is just, it's almost like a census snapshot. So it's just like, okay, currently today, Windsor-Essex is X% whatever population, and this is what our diversity looks like. That in itself doesn't mean anything, right? Diversity changes by day. Populations change, groups change, organizations change. But what really is the work really is focused on what does it look like to foster inclusion and what does it look like to build equity, right? So how do we make sure that, despite or in spite of, depending on how people feel about it, the diversity in the community, in the organization, in whatever it might be, how can we make sure that everyone is able to be themselves and, kind of flourish in whatever position they may be in? And we'll kind of talk about that a little bit more. I also want to emphasize, because I think this applies to many of us in this position, in these positions as well, or whatever positions we may be in, but about the conversation about power and privilege. So I will talk about intersectionality as well briefly, but I think we need to understand how power and privilege, affect our roles and affect the ability to influence others, to, enact change and whatnot. I always emphasize to people that, in my position, for example, I'm a visibly Muslim woman. If I'm walking down the street, people don't necessarily know who I am or, if I have a title or not. That's not really relevant to them. They just see a visibly Muslim woman. So in those situations, I don't necessarily have a lot of power and privilege if someone is yelling, potentially racist things to me as they're driving by. But in my workplace, I do have a position of leadership and I do have power over creating policies and enacting change. And so I do have power and privilege in my workplace in a day-to-day role. So it's understanding that it's not an absolute, it's not, it always exists or it never exists. It can vary from different situations and in different contexts. And so that relates to intersectionality as well. So this is a term coined by Dr. Kimberly Crenshaw in the late 80s. And I think it's really important helping us understand equity work, and it also influences a lot of the work that I do. But it's just understanding that all of us have multiple identities, right? Our age, our gender, our religion and culture, where we grew up, right? Rural versus city, where we currently live, what we have access to, if we have a disability, all of those things influence our lives. And we're all made up of all of these pieces, right, folks? We're not all one-dimensional. We all, people have multiple personalities, parts to their personalities, parts to their identity. And that's why it's really important to think about intersectionality. I say that to people, again, I'm using myself as an example, but obviously this applies to a lot of things. But, my experience as someone who's South Asian, who's a visibly Muslim woman, who's in her 30s, like all of these things point to a unique experience that I have that might not necessarily be the same experience that someone else has. So it's important to understand that and to understand how all of those factors in my identity can influence the experience that I have. And, that's, I think, something important when we look at equity work. This slide, I think a lot of people have also seen. It's one of, I think one of the most popular slides that's often shared, different versions of this when it comes to equity work. But I think it really helps emphasize in a visual way what we're looking for when it comes to equity. So, sometimes people ask about what's the difference between equality and equity. And it's understanding that, in that first slide on the left here, if someone was given the same exact resources, if someone is just inherently shorter than, someone else who's taller, there's a fence in the way, even with the same sort of step stool to sit on or that box, you still can't see the game in this sort of situation. But if someone is given a couple boxes to stand on, they can now see the game at the same way that, the folks that they're sitting with can see. Really though, what equity work comes down to is getting rid of those inequities or whatever barriers, right? Systemic barriers or whatnot may be in place. And so that's that last slide on the right there where, a fence in front of a soccer field is probably not the smartest idea, a closed fence. So getting rid of that fence allows people to see the game without needing to give any sort of extra resource in a way that they need to go above and beyond in order to see the game at the same way as others may, look for. So that is, in very simple terms, what a lot of equity work comes down to. And so like I just kind of basically just talked about, but systemic barriers are those things that are in the way. So the intention for a lot of this is, I think for a lot of our organizations is how can we, look at our organizations, think about what systemic barriers may be in place where, for whatever reason, historical reasons, they may have been in place. What work can we do right now to help reduce them or remove them entirely? So, in the healthcare space, there's lots of them. And I know that, in many other industries, they exist as well. So what can we do, to help reduce them? For example, when it comes to retention and recruitment in the healthcare space, going to medical school is very expensive, right? So that can be a barrier for a lot of people, regardless of race. It's, a socioeconomic barrier for a lot of people. So, even if you may have had the right grades or whatever else it might be to get into medical school, there are some people who do not go to medical school because they financially can't afford it. And so you'll see in the States, there's some medical schools that are now getting rid of their application fees. They're getting rid of the fees for the MCAT. They're getting rid of, depending on your household income, you don't have to pay tuition, and that helps reduce that barrier. Because again, if you have physicians who've come from all walks of life, it helps them understand their patients in a much different way than, physicians who may be from one sort of socioeconomic background, right? A physician who understands what it feels like to not have food, who, it was really hard to make ends meet, that sort of thing, can sometimes understand the experience of a patient or their family in a way that someone else who may be able to empathize, but, doesn't have the same sort of lived experience. So that, again, a barrier that I think could apply across many industries as well when it comes to recruitment and retention. Um, and then here, just wanted to talk about biases as well, just in a general sort of sense. These are things that everyone has. It's the way our brains work. Our brains process a ton of information at all times. And often through the information that we absorb, whether it's through our community, our family, our upbringing, our environment, or it's through mass media, pop culture, TV, movie, radio, music, we make shortcuts based on that information. And so these unconscious biases inherently aren't good or bad, but sometimes they can be used in a way that can have a negative impact on others. So, when that sort of thing becomes, stereotypes, prejudice, outright racism, homophobia, sexism, that sort of thing, that's when, those shortcuts aren't doing great things for us. So this is just, kind of a reminder for myself, for everyone, is that we constantly have these, we're constantly, absorbing information all the time, but what sort of information are we, learning from? Are we keeping in mind? And is that information actually accurate about, other people or other groups? And what sort of work can we do to make sure that the information we learn about others is actually accurate and fair to those groups as well? And then I also wanted to talk about confirmation bias, because this can come up across industries. But it's once again, with our brains sometimes making shortcuts, it's their ability to kind of either look for information specifically or unconsciously, but find information that confirms an already existing belief. So, we sometimes hear it in the healthcare space, for example. We will hear it when if a person is coming in exhibiting certain behaviors that frontline staff may associate with drug-seeking behavior. There may be an automatic confirmation bias that, that's automatically what that person is looking for, when in fact they're coming in and they're having, a heart attack or something else, right? So it's understanding that we have to make sure to put aside our biases in situations like this and make sure that we're not automatically assuming something based on information we may have already had before. And to make sure that it doesn't get used in a way that may hurt or harm others. And then I know we're talking about the workplace setting, so I just also wanted to talk about microaggressions as well. So, when we talk about recruitment and retention for staff, I think that is often a focus for a lot of people in the workplace. We talk about, wanting a diverse workforce and, what can we do to make sure that it stays that way. One of the things that you'll often see, cited in a lot of reports, surveys, and often in research as well from racialized staff is the impact of microaggressions. So it's, we talk about a death by 1,000 cuts. It's like those little comments, those little, it's not great sort of body language, looks, whatever else it might be, that eventually lead to people leaving the workplace. And so, it's just making sure that, folks are actually welcomed, and that they're actually part of the team, and that there isn't something that people are inherently or unconsciously doing, or consciously in some cases, to, freeze someone out or make them feel like they're not welcome or not part of the team. And so just on all of these, I always like to share this slide as well. And it just talks about, how we can mitigate some of these things and some of these strategies. And, I just want to emphasize this is talking about the individual level. Obviously, from an organizational level, you would be looking at policies, you'd be looking at the systemic things that can be changed. But on an individual level, having humility, having empathy, and building cultural intelligence are all really important parts of this. We are really lucky to live in such a diverse community, right? We're really lucky to have access to different cultures, different foods. I am hungry right now, so I'm thinking about food. But being able to access all of those things, like breaking bread with people, and learning about different cultures through their food is like a really great way to learn about a community you may not know about from before. Having conversations with people in a really like meaningful way is great too. I always joke with people that there's a difference between when I often get, and this is on a personal note, but I will sometimes get questions like, hey, why did you choose to wear hijab? Or like, can you tell me about, your hijab and your journey to wearing it? That tone and that way of asking question is really positive, and it's open, and it's wanting to hear my answer. And there's a difference between that and saying, hey, why do you wear that thing on your head? I mean, I don't really want to answer that question, because to me, that sounds like you've already got preconceived notions about what it means to wear hijab and what my personal choices for wearing it are. So again, emphasizing humility and empathy here, right? Having those conversations with people are great for building relationships and breaking barriers, and helping understand different cultures and backgrounds, but making sure that you're doing it in a meaningful and respectful way and not in a potentially polarizing or rude way is really important. And so I've got this back here because one of the points here is about collecting equity-based data. So I'm just kind of moving back after the definitions into some of the real life impacts. But first starting with this, I know I talked about this a little bit briefly at the onset. But the OH framework talks about the importance of collecting this data, and it is one of those 11 areas of action. And like I mentioned earlier, I think it is a really important area because it helps us get that data to actually have the evidence to, do or not do certain things, right? As I mentioned earlier, you want to make sure that it's not, potentially used or weaponized in a negative way against groups that may be marginalized already, but it should be used in a way to help inform future decisions. And I know that I had mentioned this earlier as well, but I just want to emphasize again that, it can be incredibly frustrating for folks to repeat their story over and over for decades to come. And so I think for a lot of this work, we are way past the point of saying like, oh, tell me about your negative experience, navigating the healthcare, system. We know it exists. We don't need people to constantly repeat their stories, but what we really need to do is collect data. We use metrics for everything, right? All of our industries, whether it's healthcare or otherwise, we love data. We love using metrics. And so this is another way of saying like, okay, this year, how many folks did we have come through our ED or our family birthing unit? What was their experience like? What went well? What didn't go well? And how can we improve it? Once again, with the states collecting a little bit more data in the healthcare space, there's a lot of information right now about the unfortunate differences for Black women giving birth versus all other races. So there is a really, really sad disparity right now in the states, where there are really poor outcomes for Black women when they go to a hospital to give birth. And one of the things in the states, though, is they have that data to show that there's a disparity. And so the hospitals can say, okay, you know what, this year we've seen, let's say 10% of our Black female patients who came in for, a a birth that was progressing normally go to an emergency C-section, what are some interventions we can put into place for the next year to help reduce that number? And how do we work with the community to make that happen? So again, parallels here with a lot of different industries, but just emphasizing again the importance of data collection and how important it can be used. I also wanted to briefly talk about indigeneity and equity, especially again in the healthcare space, as I mentioned at the top. It's, a reality for a lot of patients who are Indigenous navigating our healthcare system that there's still remnants of their experiences from, the residential school systems, from the 60s scoop, from, issues with CAS referrals, interventions with police, whatever else it might be that impacts their ability to access healthcare. So a lot of this work is helping to undo or trying to undo some of those disparities. And again, those are generational disparities, so it will take a long time to kind of unpack that. But it's also about looking at what can we do in working with Indigenous communities to do, once again, nothing about us without us, but work with communities together. So for example, in a lot of healthcare spaces, including ours at Windsor Regional, we've got a smudge policy for, ceremony to happen. So, if someone's giving birth, if there's a death, if, there's a surgery that someone's about to go through, they're able to, partake in doing a smudge ceremony before or after whatever their choice is around whatever procedure they're about to have. And so that's really important in, having that sort of merging of both like Eastern and traditional and Western medicine, and helping people feel safe in those contexts. There's also the emphasis on hiring more Indigenous staff. We're lucky to have some Indigenous navigators that work in our hospital and, help patients navigate the system and have, kind of that advocate and that safe face for them who understands their experience and also may be able to speak a similar language or be from the same community or know some of the same people. It helps them navigate the system a little bit better. So again, this is also, if folks have seen, heard of Jordan's Principle, there's a law there's we'll talk about it a little bit later, but it's also looking at the Truth and Reconciliation Commission and those calls to action. So the commission has calls to action that are general, that are for all of us. Then there's also sector specific calls to action. So going to the TRC website, looking at those and seeing what we can do to implement them in our individual settings, it can, go a long way to help reduce these inequities for Indigenous families and patients, or in your context, potentially clients, staff, whatever else it might be. So right here, I just wanted to kind of share this reality as well, in the sense that sometimes I get questions from people of like, why is this an emphasis? Like, haven't we moved on from this? Racism's over, we've dealt with it, which, is news to me because, still get racist comments from time and time. But, I look forward to the day that racism is actually over. But when it comes to anti-Indigenous racism in healthcare, these are all incidents shared here that are within the last 4 years. So these are the things that have made it to the news. So they're not necessarily the things that are happening every single day. But Brian Sinclair was an Indigenous man in Winnipeg who died in hospital after not receiving care that he should have. Joyce Akeshawan was a young woman in a Montreal hospital who actually live streamed her death because she was not getting the care that she felt she rightfully should have been getting. The nurses instead were quite awful to her, and basically live streamed the last moments of her life in an incredibly tragic way. And then there's a Niagara Health report at the bottom, which is in reference to Heather Winterseen, who was a young Indigenous woman who once again died in a Niagara hospital after coming back a couple times seeking care and never got it. So she actually died in the waiting room of the ED because she wasn't receiving care. And so the reason why I share this is that there's lots of evidence showing that this reality actually hasn't changed. And again, reinforcing the need for data collection and really showing that, these disparities still exist. But B, that like this work needs to be done, right? So, it is embarrassing, quite frankly, and really heartbreaking that these sort of things still happen. These are the most tragic scenarios. But, as we were talking earlier, about a death by 1,000 cuts, like these sort of incidents happen all the time. And they don't always result in an actual death, but they do result in harm. They result in people not trusting the healthcare system. They result in people delaying care. They result in people not wanting to come back because of a poor experience. And then potentially then coming back in an emergent situation when things are really bad, and they need, more aggressive interventions, when it would have been more ideal if they had been able to come back earlier. And so once again, this is the healthcare setting, but it applies to our education sector, it applies to in the public health setting, it applies to, automotive and manufacturing, in the sense of staff being represented and feeling like they can be themselves in those spaces. So, there's a lot of parallels here. I think obviously with healthcare, this sometimes takes it takes up a lot of our uh, time, in the sense of it becomes a news story and we see it, but these things are happening all the time. So the question is, what are we going to do to address them? And then I also just sharing from here, and by the way, at the end of the slides, I've linked a lot of these resources. So if you do want to access them, they are at the end of the slides and you can click on them. But this is one of the Canadian medical journals that has basically found or reconfirmed that there is a disparity for Indigenous women compared with non-Indigenous women accessing primary care, so family medicine, and emergency care, so going into an emergency department. The data's there, right? So again, this is just to emphasize the studies exist, the data exists, all of these things exist, but it is often our responsibility in organizations to make sure that we are able to address this in a meaningful way. This slide probably should have been a little bit earlier because we already started talking about real life impacts, but talking about a little bit more real life impacts. Like I said, it is Black History Month, so understanding once again the impact of anti-Black racism in healthcare, I think, is also very important. These stats stay with me often because they're just so they're so high in a really bad way. But 88% of Black nurses and 70% of Black physicians have reported experiencing racism in their careers. So once again, talking about recruitment and retention, right? If we're saying we want a diverse workforce, we want a workforce that's reflective of our communities and that can, best serve our communities. If folks are, facing so many microaggressions or incidents of racism or whatever else it might be in their workplace, a lot of them sometimes leave. They say, like, I can't do this anymore. It's not for me. And that's okay, for them to make that decision, but it is a loss to our system as a whole. And then we'll also see from the patient experience kind of perspective from CAMH, they found when they, again, started collecting health equity data, they found that Black patients had restraints used against them at a rate that was 22% higher than the average and 44% higher than white patients, even accounting for other differences. So again, was there necessarily a clinical reason for using that, restraint, or did that come up because of a potential unconscious bias, right? This data helps us look at that, hold hard facts, and, kind of helps us say, okay, what can we do? How can we address this and, make this experience different in the future? So there's always a lot to unpack here too. For some people, this is their lived experience and they know this is the norm of the everyday, unfortunately. And for others, this might be the first time you're seeing this information. And I think, looking at your industry and understanding, in your sector, is this the case for, racialized staff in your industry? Is this the case for, staff in your industry who may be LGBTQ? Is this the experience for staff in your industry who may have a disability of some kind? What does that experience look like for them? I previously worked in cancer, so it was the next couple slides have some cancer, research and impacts on them. But once again, looking in the States, because we have a lot of data from the States, what they found was that even though cancer mortality rates, so death from cancer, has gone down 31% since 1991, the progress isn't universal. So despite the general cancer death rate going down, Black Americans, for example, still have the highest death rate and the shortest survival rate of any racial group in the US. And then, this study went into a little bit more of looking at, the difference with private versus public insurance, and then, other outcomes. But, understanding that we've made a lot of progress and progress is great. Cancer technology has improved, treatment has improved. It's getting so much better than it was, 10, 15, 20, 30, even 40 years ago, but that progress isn't shared across marginalized groups. And so once again, how do we look at that? How do we make sure that, we can ensure that groups aren't left behind by any sort of research or progress that we make in whatever industry we may be in? And then this slide is from Ontario Health, so from CCO or Cancer Care Ontario. And one of the cool things that once they started collecting data and that they were able to do was looking at mammography or breast cancer screening and comparing it with ethnicity across Ontario. So this is zoomed in on Toronto, but there's similarities across the province. And what they found was that in regions where ethnic diversity was high, breast cancer screening was low. And in regions where vice versa, where breast cancer screening was high, ethnic diversity was low. And when you overlay it with different neighborhoods in the area, you can kind of see that a lot of the neighborhoods where there is high ethnic diversity are often also lower on the sociodemographic scale. There's a lot of recent immigrants or refugees in that area. There's a lot of other factors there as well. So again, this is just a snapshot based on population, but it does give a little bit of an indication of the work that needs to be done. And so this is a study in the Canadian Journal for Family Medicine that was pre-pandemic, but I think has a lot of good learnings still despite that. And they looked at all three of the cancer screening programs across Ontario. And what they found for them was that they worked with the Taibu Community Health Center, which is in an area in Toronto that services a lot of African immigrants. So not folks already born in Canada, but folks who may have come from the Indo-Caribbean or from the continent of Africa. And what they found was a lot of them didn't understand what cancer screening was. They didn't know it was for them. They didn't know it was applicable to them. The materials, they may have not been able to understand them. They didn't see them reflected in the materials. There was a lot of things that when they talked to community groups, they found. So what the community health center and the practitioners there did was they worked with the community. They made materials that reflected the community. They got community champions to work on this. Again, work together. And you can see from this data that all three of the screening programs, so for breast, colorectal, and cervical cancer screening, they all went up once they started doing interventions with the community. So once they were able to say like, hey, cancer screening, it's for all of us. It applies to us. This is what it looks like. This is what could happen. It was in languages that they understood. It was, championed by someone they may have respected in the community. The screening went up. So again, meeting people where they are, trying to find resources that work for them. And then even from like the staff side, from the patient or from the clinical side, A lot more research has been done about what cancer looks like on different color skin tones, right? So sometimes physicians can miss what it looks like because it presents differently on white versus brown versus black skin. So a lot more has been done in that space. But again, this is very niche and cancer specific. I understand that, but you can see the concept is there. Working with communities, if you see that there is some sort of disparity somewhere, wherever it might be, working with that community to say, like, okay, how can we reduce that disparity? What can we do? Are there, maybe stereotypes or misconceptions, maybe even misinformation about something? How do we reduce those barriers? How do we put it in a language that everyone understands? And how do we get everyone to the table where they need to be? So the emphasis here, just summarizing this slide, is getting to a place where we have culturally safe care. And I think this applies across areas, right? So having an environment, a workplace, schools, whatever else it might be, that are culturally safe, that people feel that they can be themselves, that we respect each other, respect people's differences. I was just having a conversation with someone in the hall earlier today, just emphasizing that learning about different cultures or religions isn't meaning that we're trying to convert people or trying to change people or change their backgrounds. It just means that you understand where someone's coming from. So you understand why they may have made a certain choice or why they make a certain decision. You respect their autonomy and their ability to make those decisions, and that we just share back and forth in that sort of way. So again, the emphasis is we get to a place where there's culturally safe care and that everyone feels that they can belong and participate in that society, in that workplace, as their entire self. I had this on a previous slide and I think I just didn't mention it, but it's things like, how do I take off a day for a religious holiday? Fasting is coming up for Ramadan. What does that look like with hours potentially in a workplace? And how can I shift things around or accommodate that? There's a lot of practical implications of that. If someone keeps kosher, what does that mean? What does that mean if, there's a staff potluck coming up? How can we make sure that they're included and they're part of that potluck? So it ranges from, little things that we do to more organizational, bigger scale policies as well. So just leaving here with these reminders. We all have these biases, they all exist, but it is on an individual level, what can we do to help make sure that we're checking them at all times and making sure that they don't lead to anything greater or potentially harmful to others. And then there's a list of considerations here as well. But just things to think of when talking to in different environments, right? So individual levels, things to consider, but then also things to consider more on an organizational level as well. And I shared these slides as well, so you don't have to necessarily write these all down. But yeah, thank you so much, everyone, for chatting today. And then, as I mentioned as well, all the resources that I linked in the presentation right here. So if you did want to read more or talk or learn more, you can click on it. And, as I mentioned, a lot of it is healthcare focused, but there's a lot of parallels that can apply to other areas. And then there's resources here as well. So thank you.
Okay, thank you so much, Sarah. I'm not sure. We'll turn things over to Jeff for a minute if there's any questions in the chat, or we can just dedicate a few moments for that.
Yes, thank you so much, Sarah. Lots of information in a quick 45 minutes. So it's wonderful to have these resources, and thank you for your time. We did have one question from your slide number 7, which is your role in the EIDAR. Are you able to share some policies, and specifically the chosen and preferred name policy, or maybe at some high level examples?
Sorry, not trying to give everyone a seizure, but I'm just going back to slide 7 here.
Right at the beginning.
Okay. Yeah, so we took this policy from SICKITS, so again, sharing just from everyone else who had it. And what we found was our system, so our Cerner system, was so when you register, when you come in for healthcare, you typically give your health card. So whatever your legal name on there is what gets put out into our system everywhere. And what we found was if someone was going through the transition process, if they, go by their middle name, if they had a long ethnic name and went by like a shorter version of that name, they had an ethnic name but went by an English name, that's not reflected on your health card. It's not reflected in your legal name necessarily. So we were able to kind of in our system have an area for a chosen or preferred name, and have that input at registration. It's still a work in progress, I should note, because it flows through in certain systems, but as you guys know, we went through a cyber attack. So there was work being done to get it to flow through everywhere. So wherever the legal name shows up, the preferred name shows up as well. And that work is unfortunately paused right now while we recover and rebuild from the cyber attack. But yeah, the policy, did someone want to see it specifically, or what was the question on the policy?
I was just to share it. I do have that contact person's info, so
Yeah.
we can
Yeah, happy to
definitely
share.
do that offline.
Yeah, not a problem. Happy to
Awesome.
share
Thank you.
and happy to chat more about it too, if that individual wants to talk about it.
Thank you, Sarah. Any other questions from the group here? Not seeing any. If somebody would like to just unmute their mic and even ask the question directly, you're welcome to do that as well.
Okay, well, we can certainly entertain questions after the fact as well. Would just like to once again thank Sarah very much. Very informative. Always things to learn and opportunity for self-awareness and awareness for others. So thank you everyone for joining us today. We'd like to thank the Working Towards Wellness Committee for organizing this event and for Sarah for being our speaker. Just to bring your attention, there are some resources in addition to those that Sarah has provided specific to her topic that you can see on the screen. Also too, if you don't mind, just to advance to the last slide. Many of you may be aware that the Gord-Smith Healthy Workplace Awards, we're nearing the deadline for applications for the 2023 awards. So if it's something that you were thinking about, just a reminder for that. You can follow the link or you can find us on the website. The portal is there to apply with the instructions and a toolkit and everything to submit the application. So we will be sending out a final round of reminders to promote that event, and we're really hoping that the participation level allows us to have an in-person event this year. So we'll see, but looking forward to this year's applications. So with that, thank you very much, everyone, and have a great day.